Okay, good afternoon, everyone. So we hope you enjoyed lunch, and it is now time for us to begin our afternoon session. We will hear from none other than Dr. Salifu. I am not going to introduce him again. You know that he is the professor and chair of the Department of Medicine here. And so we are very lucky to have him speak on population health. I am pleased to tell you that I was able to hear some of this talk, and I think it's just an excellent presentation coming behind the presentations we've had thus far. So, Dr. Salifu.
Thank you very much, and I'm happy to be presenting this topic. Like I said in the morning session, the new wave of terminology for health in general is population health. So the terminology is confusing. A lot of people don't know what it actually means when you say population health. So my goal this afternoon is to give you a framework of how the thought process for population health came into being and how it is being framed moving forward in terms of health disparities. I have a number of disclosures to make, but no conflict of interest. Okay, so we will talk about the background, the rationale for population health, how it came into being, how it is related to the social determinants or the health determinants of health, and then we will provide some summaries and some case studies for you to take home with. Okay, so let's start with the definition. When you say public health, what do you actually mean, right? I'm sure you all know what public health means. That is anything to do with preventing disease. It's so common, right? When you say public health, you actually mean the underlying terminology is really preventing disease. That's public health at the population level. When you say population health, it is almost similar to public health, but it's not public health. When you say population health, you actually mean controlling, not really preventing. You want to control the disease. So the underlying terminology there is how to control disease when it has already happened. And how do you control the disease? You want to control the disease by using what we call performance measures to prevent the disease, to diagnose the disease, and to treat the disease. And for the most part, these are chronic diseases. So we're not talking about measles and influenza and all those kinds of things that come seasonal or episodic. We're talking about chronic disease management and how you can use quality measures to be able to prevent the disease, diagnose the disease, and treat the disease. So that's population health. Okay? Now, you wonder why is population health not public health? And the answer is that the term population health actually came as an evolution of cost reduction. That is the difference. You're essentially doing the same thing, but the reason why we're focusing on population health right now is because the healthcare system became too expensive at some point. And now we have to figure out a way, instead of treating an individual at a time, how can we treat the population at a time to prevent disease? That's what population health is all about. So it is some kind of population health, but it's more in line with trying to make sure that for chronic disease management, we're managing the population to prevent chronic disease development and control. So the US healthcare system is very expensive. I don't think anyone can deny that. And that is a big problem. And I already mentioned that the evolution of that terminology came as a result of this problem. It's just too expensive in the United States. And I'm going to be explaining how that has happened. This is the world represented by what we call the OECD countries, the Organization of Economic Cooperation countries. That is the developed world, and how they are doing in various measures of health. And one of them is infant mortality. If you look at the red line here, the bar here, this is the United States, and how we are doing in terms of infant mortality. We are number 34 in infant mortality. All right, even though we are spending a lot of money. So that is not good. If you look at the life expectancy, which is actually very dear to my heart, anytime I give a talk, I always use this slide because everything about health disparities comes from this slide. In other words, some people are living less than other people. And there has to be a reason to explain why some populations are just living less than other populations. But be it as may, look at the difference between the life expectancy for the thick lines are Americans, and then this is USA for men and women. This is the men, and this is the women. This is the average, it's around 79. But you can see that the men are living much shorter than the women. All right. This is the United States. And then you wonder, what is the cause of death for our population? What is the leading cause of death for our population? Why are we not meeting the life expectancy compared to the rest of the world? And you see that heart disease has been mentioned this morning already. Heart disease takes the biggest chunk. Cancer is right behind that. And unintentional injuries is also right behind that. So these three diseases, cardiovascular disease, cancer, and unintentional injuries, actually account for the majority of deaths in the United States. So that's huge. So if you were able to design a system, a population strategy, see, this is why population health is so important. If you were able to design a population strategy that addresses just the big diseases, you would actually eliminate a lot of the health disparities. That is where the issues are happening. So if you find out where they are happening, which is what we are showing right now, and you actually design strategies to address it, you see that you can reduce health disparities in general. And of course, if you address major policies and procedures to address all of these major causes of death in the United States, of course, you're going to be addressing health disparities at the same time. So we live less than the rest of the world, and we spend more than the rest of the world, right? If you look at the OECD countries, that is the Organization for the Economic Cooperation for developed countries, you see that the United States is somewhere around here. We spend a lot of dollars per GDP. In other words, the amount of money we spend on an individual in the United States is about $8,500. And in those countries in Europe and other developed countries, they spend $3,332, which is 2.6 times more. So we spend more money and we get less outcomes than they do. And you can't keep doing that. You're going to go bankrupt. So if you now want to see where the expense actually is, the biggest portion of the expense is, this is data showing you the last year of life and how the cost is allocated to that last year of life. It's about 15%. So 15%, that's a big number. 15% of the cost of healthcare in the United States is in your last year of life. So we are busy spending a lot of money and not getting the outcome. We're dying anyway, and we're spending a lot of money. So much money to die. That is true. Somebody said that is true. All right? So that is the problem. We spend a lot of money, right? It's a lot of money. It's just too much. You look at this in the United States. That's the bar here for US. Long-term care and then hospital care is just big numbers. We spend a lot of money in that sphere. Okay? So the point in this introductory slides is to tell you that we are not doing as well as the developed country, the other developed countries, but we spend a lot of money trying to get those similar outcomes. So this, statistic has been there for a long time. Since the 1960s, the same thing has been observed. So people began to think about different ways of trying to reduce cost, because you can't keep spending money and not getting the results that you're looking for. So cost becomes an issue. So how can we reduce cost? So before the 1980s, the way we paid for the healthcare system was called fee-for-service. You see a doctor, you pay the money, you get your healthcare, you're gone, right? Or you come into the hospital, there's a mechanic that pays the hospital, and then everybody has a nice day, and then the issue is resolved. Between 1980 and the 2000s, there were new ways to pay for healthcare. And that was the birth of what we call the managed care organizations. Now, you can tell from the name, managed care organization means that we're going to manage your health. We're going to find a way to manage your health so that it's not too expensive for the healthcare system. And in trying to do so, sometimes managing the health is not necessarily in the interest of the patient. It's in the interest of controlling the cost. But somehow there has to be some medium where we're actually able to provide some level of quality care and then reduce costs at the same time, and that is the challenge. And then in the 2000s, then came additional models of funding healthcare. And I'm going to just mention them. One of them was called the accountable care organizations, which means that organizations, which included the managed care organizations, if you could come up with a plan to save dollars, we will share the money with you. So that was an incentive for people, managed care organizations, to be able to create a mechanism to save dollars for the CMS at the end of the day. And if you save the money, then you can have a share in the money with the government. So that those organizations were called accountable care organizations. Then another methodology came, medical homes. There were other methods for performance. That's an incentive-based payment. In other words, if you do well in quality metrics, in other words, if you're providing the best care for your patients, that is, the blood pressure is controlled, the diabetes is well controlled, your A1C is 7, your cholesterol is controlled. If you are diabetic, you get your protein checked in your urine to make sure you don't get kidney disease. You get your annual checkup for your heart to make sure you don't develop cardiovascular disease. You get your pap smear, your mammogram screening. If you're a child, you get all the immunizations. That is, if you did all the good things, you can actually save money. And if you did all the good things, the system was willing to pay the doctor, the hospital more money. That system is called the incentive-based payment system. And it's actually happening today, actually. Now, why do we have to do that? That is because the system is gearing towards reducing the cost. So the more we are able to do these things to reduce costs, the more the healthcare dollars are going down, right? We are spending less in the healthcare system. But of course, we always have to balance the care we're giving to patients, the quality, and then the cost at the same time. Okay? Then in all this sequence of events came the terminology population of health. So it's not a random terminology. So when we say population health, even though it's more like synchronous to the public health, it is the result of cost. Population health is the result of cost, whereas public health is not the result of cost. It's just because we know that we have to do so many things to prevent disease in general. But this terminology, population health, came because of these ideas that were introduced to reduce healthcare costs and to increase quality for patients. And the next step, maybe after population health, is going to be what we call precision medicine. In other words, how do we actually treat patients as an individual, get the quality of care that we want to get from that person, and then be able to treat the disease at the same time at the lowest possible cost? That's precision medicine. So in other words, we will know so much about you, so much so that we are going to be precise in what we prescribe for you. We are not going to give you Bidil. We're not going to give you something that you don't need. We're going to know your genes, your environment, your everything so much so that we are going to give you a prescription that actually works for you. That is precision medicine. And hopefully that would also reduce the healthcare dollars that we're spending in the United States. But today my topic is going to be population health, of course. So how is it done? How is it done? In order to reduce costs, we have to do something to get there, right? So how is it done? So I'm going to give you examples, and then you can figure it out yourselves. Patient A and B have heart failure. Both receive reminder calls for visits, but patient B is depressed and does not answer the phone calls. How do you design care for patient B to make sure medical interventions are as effective as patient A? That is population health 101. Okay? Because we want to make sure that everybody gets the care. So we have to design something different for patient B. That's what we have to do. So what do? We have to design something around visit compliance. We have to design something around medication adherence. We have to design something around mental health illness, right? Because this patient may have depression, I already said that, but it may be deep enough to require medication management to make sure that the person is now more inclined to respond to the medical interventions. And we also have to address the social determinants of health. Maybe the person couldn't just afford coming to the doctor's office. Transportation, right? So we are going to create a care plan that addresses all these issues for patient B. And if you don't do this for patient B, you're going to get health disparities because patient B will not be able to make up for the visits. And therefore, the outcomes for patient B is going to be much, much less than the outcome for patient A, who's able to come to the clinic and get the care freely, right? So that is population health, being able to create systems that make sure that people who are unable to make it actually are able to make it. So it requires infrastructure, a lot of infrastructure. Some of them I cannot talk about today because there's a lot of technology involved, a lot of software, hardware. That is big business for managed care companies to be able to put that together to look at what is going on with the population, so that we will not be able to address today. There is also analytics that goes along with that to be able to say, okay, in your population, how many people have blood pressure more than 140? How many people have A1Cs more than 7.5? That is how many people are uncontrolled. How many people have not had their pap smears? How many people did not get their colonoscopies? There has to be some way to analyze the data to come up with the statistics for the population so that we can then design specific interventions to address those outliers. That is population health. In other words, we're in the room here, we're 100 people. We expect that everybody will get the same level of care, but it doesn't happen like that in general. We know that some of us will have high blood pressure, but not all of us. So the job of population health is to identify those people who are above 140 for their blood pressure measurement, systolic blood pressure, and design specific intervention to address those people. Then you see that everybody is now 140. All right, that's population health. So you analyze the data, then you identify the risk population, right? Now you have to provide the care to those patients. That's called care coordination. Now you have to provide a certain level of care coordination so that there is now contact with that person. Without that physical contact, you're not going to get the result that we're looking for. Somebody really has to be in contact with the person and triage the person along the line where the person is supposed to go, which clinic, and so on and so forth, or which hospital, and so on and so forth. Don't miss your appointments, that kind of stuff. That is called care coordination. In the absence of care coordination, it is just not possible to have significant impact in terms of population health. So those are the components. So when you hear that somebody is walking around with blood pressure of 170, this patient is a bad diabetic, right? You see, you are blaming the patient. You are blaming the patient. The patient didn't show up in clinic. This patient is non-compliant, right? You are blaming the patient. But look at what is involved to be able to get to the patient. It's a lot involved to be able to get to the patient and make sure the patient actually does what they are supposed to do, right? So there is a national organization called the National Committee for Quality Assurance, the NCQA. They came out about 15 years ago. They came up with what we call the HEDIS measures. That is the Healthcare Effectiveness Data and Information Set. It's called the HEDIS measures. That was designed to collect information, claims data into one data set that everybody else can access. So all of you who have seen a doctor before, your data is in this HEDIS database. It's sitting in there. All right? And the goal of healthcare organizations and practices is to access that data to be able to design population health strategies. That's what we're supposed to do. So the platform has already been created, right? And these are the measures. We have measures in care, access to care, experience of the care itself, how we utilize healthcare resources, how health plan is in the mix, and how we're able to collect and use a lot of the information that we collect. So all these measures, when you get into the hospital system or clinic system, all these measures are collected and they are dumped into the HEDIS measures data set. And the goal of healthcare organizations to be able to access this information and so, okay, within my environment, within Downstate or within Health First, how many of our patient pool do not meet the measures? Do not meet the measure for blood pressure, do not meet the measure for diabetes, and so on and so forth. And then we can then identify those people and then say, okay, we have a pool of 10 community-based workers or social workers or case managers, and their job is to identify these high-risk patients and manage them to the extent that we will bring down their blood pressure, bring down their A1C, and make sure they're all getting their pap smears and mammograms done. That is population health. Okay. So you see that's different from public health. I think at this point now you understand the differences. It's different from public health because we're doing specific intervention on specific people to level the playing field. That's population health. And now we have the tool to do that. The tool is now national. That is there. It's a question of whether healthcare systems, insurance companies would put the right people together to access that information and do what they are supposed to do to impact healthcare. That's what is missing. Otherwise, the data set is there and can be accessed. So this is what you get. If you actually want to access that data set, this is what you actually get. So let's say SUNY Downstate was to implement a population health strategy, right? We will have to put an IT team together. We will have to put an analytics team together. That team will access the HEDIS measures database, and then they will extract our patient pool from Downstate, and then we will come up with this information, just one sheet. It will summarize everybody. For instance, as an example, it will tell us that for patients with diabetes, we know if you are on a class of medication called angiotensin converting enzyme inhibitors, ACE inhibitors. It's a group of blood pressure medications. If you are a diabetic and you are taking this medicine, you would live long. We know that. So it's a quality measure. So if you are a diabetic and you are not on this medication, it's not good. We know that for sure. So the HEDIS measures will tell you, right? So as an example, in this example here, your scorecard, this is your scorecard. This practice, the patients with diabetes who got an ACE inhibitor was 64%, which means that they're not doing good. They had diabetics, but only 64% of the diabetics were receiving ACE inhibitors. That's not good. So what do you need to do in terms of population health? Now the case managers, the social workers, the community health workers, their job is now to design a plan that will reach out to the 36% of the patients who didn't get this control or who didn't get this prescription to get the prescription. That is population health. So if Downstate could do that, and Kings County could do that, and Methodist Hospital could do that, NYU can do that, Health First can do that, then Aetna can do that, then Empire Blue Cross Blue Shield can do that. Where is the health disparity? In other words, if everybody was willing to design a system that would make sure we identify problem areas and address the problem areas directly, then the disparity would disappear, right? Another example would be what? Let's give another example. If you had heart disease, there is the bad cholesterol should be, the number of people who have the bad cholesterol should be, the number of people whose bad cholesterol is controlled should be very low. Should be very, very high, right? The number of people with the bad cholesterol who are actually controlled should be very, very high. Should be 100%. In other words, your bad cholesterol should be very controlled. Let's look at this example, for instance. In this example, in this practice, 67% of the patients who had heart disease had the bad cholesterol controlled, which means that 33% of the population did not have their bad cholesterol controlled. So the job of the system is to design a system that identifies those 33% of people and brings down the LDL. Go ahead.
How inclusive is this database vis-a-vis, let's say, minority data in let's say, in Brooklyn? How inclusive?
This is a healthcare data set. So this is about access to the care itself. So this is about people who have already accessed the healthcare system.
No, I know, but
yes.
The database from NCQA.
Yes.
How inclusive is it vis-a-vis minorities?
It includes
Meaning,
everybody.
Where do they get their data?
It includes anyone who has accessed the healthcare system for primary care.
So where do they get it from? From health insurances?
Yeah. This is the claims data because everybody who comes to the clinic, the primary care clinics, the doctor has to bill for the service, right? So the claims goes to a central depository and it's pulled into this data set. Okay. So if you don't meet your quality metrics, providers are subject to payment reductions when they don't meet their quality metrics. So population health strategies uses quality to drive down the cost. So we know that if I am the practice, if I'm getting only 64%, they're going to reduce my money. I'm going to do more to get 69% or 90%, and I'll get more money, because the more you meet your quality metrics, the more money you make. So now it's an incentive to be able to do better, right? That is population health. So we are incentivizing the healthcare system, the providers, hospitals, insurance companies to do a little bit better job. And if you do a good job, we'll give you a little bit more money. Right? And this is how it looks like. So right now, the cost is very high and the quality is very low. That's where we are in the United States. What we want is to level the playing field, right? We want the quality and the cost to really be even, right? And I think we can do that. But the best scenario really is to actually drive up the quality and bring down the cost. That is the eventual goal. You drive up the quality, you bring down the cost. That is the eventual reality. That's what we want. And I think that population health is the way to go, because people have to understand that it's not everyone who has a specific problem that needs to be addressed. But there are people who have specific problems that if you don't address them, they just highlight the issue of health disparities. And our job is to make sure we find those people and address it directly. Okay, so this is the care coordination. So care coordination is not cheap. That is why not everyone is doing it. If it were cheap, like the way I'm explaining it, then it would be done, right? But it's not cheap. Look at all these individuals around. This is the patient, the family. You have all these systems around the patient. So we have to develop an infrastructure around the patient to be able to coordinate the care properly in order for the patient to get the quality of care that they deserve. And this is the limitation. This is where the limitation is. So besides the infrastructure, getting the people to analyze the data, you also need to set up this system to be able to manage the population. So we have to invest money to make the money. And that is where the challenge is right now in terms of population health. So because there's a lot of investment, physician practices typically will not be able to do population health management that much. Hospital systems can do a little bit. So for the most part, population health strategies are at the level of insurance companies, right? Because they have the infrastructure, they have more money, they're able to provide all the resources to do that. But even then, it's not every insurance company that has the entire infrastructure to be able to manage population health. They still rely on hospitals, providers to be able to help them manage the system, their lives. So in terms of population health, you understand how it is done now. It is a very good methodology to reduce the cost and increase quality. That is population health. But there are population health determinants. What determines population health? If you look at this chart here, there are a number of determinants of population health, and some of these issues have been addressed already. But if you look at the contribution of societal and social characteristics to population health, it's a huge chunk. It's a huge chunk. So the medical care, I believe we can provide. You know, the genes, we can change them, like it was said this morning. Health behaviors, maybe we can change. But if you add health behaviors and societal and social characteristics, that is the biggest chunk of the problem for population health. So unless these issues around social determinants of health are addressed, it's really, really very hard. The patient cannot come to the hospital because they couldn't get transportation. Something very basic. They can't get that basic thing done. How are they going to end up in the clinic, the doctor's office or provider's office to be able to get the care that they deserve or they need, right? So it is not unwise then to say that for population health to be effective, the social determinants of health must be addressed and really addressed properly. And this is how it looks like, the social determinants, right? You have education, you have economic stability, you have neighborhoods and the environment, you have health and health care. They are different things. Health is different from health care. We want everybody to be healthy. That's the goal. The goal of population health is actually get everybody to be healthy, right? Healthcare is different. You are really sick and you really need care, so we provide the care for you. But the goal is really to get health done. And then your social and community context. All these make up the social determinants of health. So it's complex. That's why the conversation is ongoing, right? So if you are interested in health disparities research, this is your slide. All the questions are in this slide. You can ask questions on economic stability. You can ask questions on neighborhood and environment. You can ask questions, and this also includes the criminal justice system, I believe, crime and violence. You can ask questions around health and healthcare. You can ask questions around your social and community context, right? Even civic participation is part of health disparities. You don't go to the polls, how are you supposed to make your voice heard? You have to vote. It's part of your responsibility towards your own health, because people are going to be making decisions on your health, right? So all these things are very important, and that is why the conversation around health disparities is so complex, and we will never be able to find one solution that, resolves everything. But I think the concept of population health and trying to drive, insurance companies and healthcare systems and practices to be able to understand the idea of population health, and then provide, strategies and policies to identify high-risk patients and treat them is really a very good one, at least in the interim. So when you don't address the social determinants, it results into health inequities. That's what the net result is if you don't address them, right? And that is basically the differences which are avoidable. So all this discussion this morning was centered on avoidable problems. And the slide I showed you, that is the Sentinel slide, that is really, those are issues that can actually be avoided. Anything that can be avoided, if you don't avoid it, always leads to health inequities and of course health disparities. So this is what we mean. You have 3 people, right? And each of them is given a stool. You have a tall man, a little man, and then a little man, right? And they all give him the same stool, right? This guy is tall enough to be able to see the baseball field. This guy is a little enough to see a little bit of the field, and this guy doesn't have any chance at all to see the field, right? When we say equity, what we mean is, can they all see? What can we do to make them all see the field? That's it. We're not really taking away anything from anybody. What we mean is that this guy can already see the field, so let him stand and see the field. This guy needs a stool anyway to see the field, so let him be there to see the field. And this guy just needs one more stool, to see the field. That's what we mean when we say health equity. We're not taking away anything from anybody. We're not disadvantaging anybody. We're only saying help the person to see the field. That's what we're saying. But in reality, that is what we are living right now is reality right here. This guy really has a lot of stools. That's what we have. So he is seeing the field so clearly, and there is no chance for this guy. He will never see the field. That is the problem. So the conversation around, population health is around equity. That is, what can we do to bring people to see the field? All right. So I know some of this stuff has been discussed, but I want to put some context to it. In the 2000s, there was a report around health equity. And this report, I like it a lot because it talks about equality, which is the subject of this conversation. We provide healthcare, so we have to measure the quality of what we provide. So we are measuring the quality of the white population, that's non-minority, and we also measure the quality of the minority populations, right? And there's a difference. We already established there's a difference. Dr. Levis made it clear that there was a difference. So there's a difference in quality between whites and non-minority and minority populations. That difference, what is it? That is where the trick is. What is that difference? Is the difference because of clinical scenarios? In other words, patient doesn't just want something done. Is it because the healthcare system is just too complex? Or is it because there's discrimination? That is where the questions lie. And discrimination simply means, are you biased towards the person? Are we stereotyping? Or are we just uncertain about diagnosis? Right? But we'll lump them all into discrimination. And what the Institute of Medicine found, and this is the final say in medicine in the United States, it's called the Institute of Medicine. What they found was that disparity really has nothing to do with what patient prefers for themselves. Whatever you prefer for yourself is what you prefer for yourself, right? But disparity really, comes when you have a complex healthcare system and when there's discrimination in that complex healthcare system. So we have to be conscious about that. I'm going to give you two case studies that will illustrate that same point. The first case study has to do with what we call the Vital Brooklyn Project. This was a project very dear to Governor Cuomo's heart, because I'm sure people are talking to him about the social determinants of health and, lobbies and all that stuff. So he said, look, we have to solve this problem in New York State, and we have to use at least one example to illustrate the point. So this Vital Brooklyn project was announced in March of 2017. It was meant to socially engineer underserved communities in black neighborhoods in Brooklyn. That is central Brooklyn, basically. So what was the problem? They said, this neighborhood, the unemployment rate is unacceptable, food stamps, physical inactivity, number of murders is just too high, the preventable disease is just too high, and we have to do something about it. So you see, we have social determinants, and we have to do something about it. So let's bring about everything that we can do to solve this problem. So what are we going to do? We're going to invest $1.4 billion into the system to solve the problem. And how are we going to do it? We're going to invest about, 40% of that money, that's about $600 million for housing. And I guarantee you, if you walk around Brooklyn, if you go on New York Avenue and other areas, you see things like popping up that is from that project. All right? A lot of it is from this project. We have to change the way housing is done. It's too, yeah, you have to spend the money to get the result.
Within this project,
Yes.
there is a disparity.
But we'll take questions at the end. But that's why I say case studies. So we're going to see what he did, and let's see whether we can understand what it means in terms of health disparities. So that's a case study. So anyway, so $600 million will go into housing. That's his plan, right? The other $700 million, he wants to create a new healthcare system. A system that would create resources for primary care in Central Brooklyn so that there will be access to healthcare. That's the plan. And how are we going to do it? We are going to do for the housing, they are going to do all these projects. There is, $400,000 for some reef project restoration. There is some gardens, 22 community gardens to be built. I believe there were so many housing, about, I believe 800,000 or so new housing units to be built in Brooklyn. New housing units to be built in Brooklyn to house new people, all right? And then there is a state park. I think if you are on the Bell Parkway, you see some new state park on the Bell Parkway. That is part of that project. So that's this red zone here. So all this is going to happen in this red zone, okay? And this was designed to address social determinants of health and also to provide funding for a new healthcare system in Brooklyn. Now, what does it mean to you? This is what he is trying to do, but what does it mean to you?
So he says, all that sounds good on paper, but in reality, it's not helping the people that it's supposed to be designed to be. Because the people that you want to help, they're not getting it to those houses.
Okay, so the people are not getting to the housing, so that's the problem. What do you want? You want to make a comment? Quickly though, before I continue. Okay, so the comment is that, yes, it's a good plan, but when the housing is finished, likelihood is that the people who actually need this housing will not be in this housing. And then it will perpetrate. The health disparities will continue to perpetrate. The social determinants of health will perpetrate. But I think that's a good case study. Think about it. I just kept it as a case study to think about it and how policy can influence how we address social determinants of health. The next case study I want to throw out there, and again, I'm not making an opinion about this, I'm giving it as a case study, and then you think about what can be done at different levels to solve the problem. This is a government level to solve a problem that I'm giving you. But this is the next case study. This is called the Medicaid redesign, also known as DSRIP, okay, in New York State. So what was the problem here? The problem was that we have unnecessary and costly emergency room visits by Medicaid eligible patients. So we have so many people come to the emergency rooms, they consume a lot of resources and they make it too expensive. So we're going to invest into this problem and we're going to reduce the cost associated with this problem. So what did they do? We want to reduce the unnecessary hospital admissions by 25%. That's the goal, right? So what are we going to do? We're going to invest about $6.4 billion to develop a new healthcare delivery system. But how are we going to develop that? We're going to give the money, for the most part, to managed care organizations. The managed care organizations would develop what we call, they will develop a network of PPS, performing provider systems in New York State, PPSs, 25 of them in different locations in New York State. Each of the 25 PPSs will receive the money, and their job is to do the projects. Their job is to do the projects to reduce health disparities in some of these areas. So hospitals, some health homes will receive the money, hospitals and other providers will receive the money, and community-based organizations will also receive some of the money. What are the projects? So there was a systems transformation project that is create integrated delivery system, which is basically create patient-centered medical homes, create health homes, create medical villages. In other words, just redesign a new health system where people can come in and get the care in a coordinated fashion. And they were willing to fund it through the PPSs. So if you were a health system and you could come up with a project that will address this, you would actually be funded. And that started in 2014. Okay. Another project was what we call the clinical improvement project, right? So this was around behavioral health, to try to see whether we can integrate behavioral health, adherence and all that stuff into how we practice medicine in clinics and in hospitals. All right. This is another project, population-wide project for prevention projects. So this is just an example. There were 11 projects in district. And each of the projects was designed to address a specific problem. Okay. So the money went to the managed care organizations. They formed the PPSs. The PPSs formed conglomerates of other organizations, and all the members of the organization needed to do was to come up with a project that made sense. And if you came up with a project that made sense, you get the money. And the goal was that if we did the right things, we can reduce the hospital admissions by 25%. All right. So at this point, where are we? It's now 5 years from 2014 to 2019. That's the project. The project is being renewed right now. They were actually able to reduce the hospital admissions by, it's actually less than 25% now. It used to be 30 and more. Now it's around 16, 17%. So the unnecessary hospital readmissions has been reduced, which means that they are now able to cut costs. The problem is what she raised. You create a system, and the system doesn't become sustainable, which means that how do we transform these projects so that they become sustainable? That is where the problem is. Because we know that the project was successful. So if you then demonstrate the projects were successful, what is the mechanism to make sure these projects actually are sustainable and long-lasting, so that we can continue to reduce the number of people who can actually see a doctor and don't need to go to a hospital? That's basically what this means. So we're providing better access to patients. Okay? So that's where we're starting. So that's another case study for you to think about, and then you can interpret in your own ways. All right? So these are, government interventions to reduce health disparities in terms of health equity. So there are ways to do it. These are just two examples to show you that there are ways. We will do it at our level. Health First will do it at their level, at the insurance company level. Government has a role to play, but the issue always is, how do we maintain things once we get it running? How do we make sure these good ideas are actually good ideas and they don't get derailed along the line? That is always the challenge. And so the more we have people engaged in the conversation, the more we have people talking to the people making those decisions, right? We give you the information, you participate in the discussion. When you meet your Congress people and all the other people, that is what you should be reflecting to them, so that they know that these government interventions needs to be sustainable, not a one-time thing and then you run away and then the system falls apart again. All right. So the system is very expensive, and we know that we have to keep talking about this because it's just cost saving. And these are just slides to show that if we did the right thing, we could save at least $1.2 trillion if we did the right thing in health equity. In other words, people are able to go to the doctor. They want to go to the doctor and actually go to the doctor. People don't need to go to the emergency rooms unnecessarily, right? And so on and so forth. And then we have enough environment for people to exercise and walk, good food for people to eat, and so on and so forth. if we had all those things which we all know to do, and government has experimented on some of these things and they actually work, then there's no reason why we shouldn't be saving $1.2 trillion, which would then be reinvested back into the system to create better environments. So this is the model. So the model is individual level, interpersonal level, the organizational level, community level, and public policy level. All these levels have solutions. And wherever you get yourself involved, you have to get involved. But the one thing that I know we can do is make sure that we are all engaged in the conversation. In other words, you come to a conference like this, you go to your environment, you spread the word. That's what we can do, right? You spread the word. All right. So in summary, the cost of healthcare in the United States is simply too high, and it's not sustainable long term. And many strategies have been employed to reduce healthcare costs, right? But are largely symbolic and sometimes not effective. As our counterpart said, population health is just one of those strategies. It's just one of those strategies to reduce healthcare costs. But it's also founded on value-based payment. In other words, we are going to pay you if you perform better. You get more money. Actually, I have a conversation with Dr. Bean afterwards, actually before the conference started, and she was giving me examples of how we could actually improve, because we're doing a downstate, because we're doing a good job taking care of patients, but we're unable to put the information in a way that is translatable into value-based payment. So those are challenges that everybody has to know, and then at least for the healthcare system providers to know, and then be able to design systems that will reflect what they are doing. In other words, you have to show that you are doing quality work, and then you can be paid for the quality work that you're doing. Right? And of course, addressing the social determinants of health is priority. Whatever we can do to address that area is very hard for individuals to really address social determinants, but whatever you can do at your local level, help your family member, and report. You can report things to the social system for interventions to be taken up and executed. Whatever you can do at that local level, you should do. But of course, for the most part, the big interventions and social determinants usually come from organizational levels, insurance infrastructure levels, and also at the policy levels with the government. So I'll stop here and then we take some questions. Yes.
Thank you, David. Great presentation. I guess that there are certain models that have been in place to address care coordination for years. I work in the HIV field here. We've been funded not through district, but through directly from the State Department of Health to address a specific problem and have certain measurables. The measurable that we use, the outcome that we look at most likely is viral load spread. We've been doing this with a very small scale, tightly knit team for years. I've become very skeptical of larger scale schemes when I have a great company like Health First. I'll have a lot of great things to say about Health First. But what happens is when we have a fragment of our overall clinic population, say 20% covered by one insurance company, 40% by another insurance company, bring their care coordinators, instead of quotes, to a team to say, well, what are you doing? And you have to report all these deliverables to us now. We're already reporting them to the state. It gets into a lot of inefficiencies, duplication of work. And what happens is a managed care organization like Health First pays a value-based payment to the hospital, which never gets back into the program that did all the work in the first place. I don't want to name any hospitals here. You know where I'm going. So there's ways in which this rolls out, which has inefficiencies built into it, at least from where I sit in the larger scheme of things, which really need to be thought out. Look at existing models that are already working, and why come up with these grander schemes and duplication of models on a larger scale when there are already systems that are in place that are already working in the general philosophy of that.
Well, that is a comment, but I would frame that into a question. But the comment was, you have one clinic really doing very well, right? He's running a good clinic. It's running very well. Outcomes are good. But the patients have different kinds of insurances. And every single insurance is coming up with a different plan for care coordination. And so it becomes challenging to manage that infrastructure. I don't know how we can solve that problem, but what I can say is that we have to use the strength of the care coordination team. It's a resource that comes to the clinic, and whatever the best we can do with the resource that comes to the clinic is what we should do, which I think you are doing, of course.
Right, well,
Yeah.
what I'd say from my
Yes.
experience of implementing this successfully, having some outcomes, is that care coordination, even if the money is channeled through an insurance company, should be somebody who is part of the clinic team, not somebody from outside, because somebody from outside doing quote-unquote care coordination doesn't really know what's going on with a lot of the patients. Will find that, I was saying from experience, at least in the HIV field, you'll have a care coordinator in the insurance company who's responsible for a couple hundred people, whereas somebody in the clinic may be responsible for 40, 50 people, knows these social determinants of each patient much more closely, and will be directly working on those things.
It's a very complex question, but I'm getting ideas from what you're saying. But my thoughts about what you're saying is, if there was a policy to say that because we want population health and we think it's a reasonable solution for quality and cost at the same time, why should the insurance company come up with the care coordination in the first place? Just fund the person providing the care to do the coordination. Right, that would have been the ideal scenario, so that we don't have multiple coordinators coming into one clinic and they're all doing different things and they're all giving you different outcomes. So the best thing would have been we pay the provider then gets the care coordination done in the way that they feel comfortable with to get the outcomes that they're looking for. That would have been the ideal scenario, but maybe we should write a white paper on that with Dr. Rabin. You have a comment?
Yeah, I do. I mean, I think what you're raising is really important and critical, but it speaks to why this population health versus public health
Yes.
dichotomy impacts some of your patients or our members or people, New Yorkers. It's that cusp between population health and public health is the disparities or equity discussion, right? So that's where we know that we need some additional widgets.
Yes.
You know where the widgets should be. We can't know, through the HEDIS status,
Yes.
for
Yes.
example.
Yes.
And I do think there's an opportunity to sort of propose new ways of new models we should test, et cetera. And I think what you're raising, that's why this presentation is so important,
Yes.
to just ask us a question and
Yes.
not give us a solution.
Yes, yes, yes.
And I think that's what this conference is about.
Yes, yes.
Where those populations that are not benefiting from, their access, et cetera, as we discussed earlier.
Right.
That's kind of the
Right. I think that is subject to more research. In other words, I'm not sure that there is a mechanism right now to reimburse the care and then adjust for payment for care coordinators. You see, that would have been the ideal scenario. In other words, the money that you are getting into Downstate or your clinic is not adjusted for payment for care coordinators. You see, that's the problem. So now I got what you mean. So if you, the payer, can adjust his payment by the presence of care coordinator, then he has the resources to get his own care coordinators. He doesn't have to rely on you to provide the care coordination. Then you would now be responsible for the population health management of your system. And then you'll be done. Have a nice day. So let's write a white paper on that. And maybe we can do a demonstration project. So that's a good one. Okay, yes, question please.
My question is, it's a question and a comment. What about structural issues? If we took your slide, there are the three people trying to get a vision of the field.
Yes.
That's at the individual level. The
Yes.
person who needs the care and the guy who can't get the care because
That's right.
you guys are taking up the space. But I think part of the issue too is that's seldom addressed is at the organizational and policy level. For example, the slide you showed with managed care organizations being in charge of
Yes, yes.
Sometimes it's the same people who get the same money over and over again, and they're doing things that are not necessarily going to help the population, because it's all about getting the money for me, and I'll just write my little paper grant and say, I'm switching and doing this, whereas that's not the case. It's usually about keeping the same staff and doing the same things. So I think until such time as people think about that, the disparities at the structural level, because if you have the same people then doing the same old stuff, that disparate stuff that you talked about,
Yes, yes, yes.
is very rampant. I guess that's a slight.
Yes, yes, yes. I agree with you. I agree with you. So I don't know what else to say because I agree with you 100%. In other words, let's say for instance, $6.4 billion. Let's say the state of New York had $6.4 billion and say, look, guys, is there anyone in New York State who can give me a project? And just open it up,
Yes.
right? Give me a project to show that you can reduce the household admission by 25%. I'm sure there would have been respondents. But they didn't do it that way. They set up a structure that absorbs the money in a lot of overhead costs, and then by the time it dwindles down to whatever we're supposed to do, maybe the money is not enough, who knows, right? So those are the complexities of the slide that I was talking about, which is what I'm trying to refer to here, which is this one here, this one here. This area here, the ecology of the healthcare system. In other words, we've never been able to simplify the healthcare system. That's the problem. That's where the disparity itself is coming. So if the money is not coming to the right person to do the right research or do the right care giving or provide the right care, but it's going to somebody else to take a cut for administrative overhead, then it will then come down for another system to take another overhead, then come to another system to take another overhead before it gets to the patient. You think there'll be money left for the patient?
So at the end of the whole.
So it's very complex. That's the problem.
At the end of the district, then you say, not at the end,
Yeah.
with the long, they'll say, oh, those people are not
Yes.
gonna comply
Yeah.
anyway, then it really is a lot more complex.
Or they'll say it didn't work.
Dr. Bean has a comment.
Yeah, so I think it's more encouraging than that. Managed care did not get the district funding. So
Yes.
the district funding actually went to delivery system.
Yes.
I'm not saying that the outcome could have been better or not, but what I did learn through that process, and you had it on that slide
Yes,
with all
yes.
the statewide
Yes, 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 yes,
organizations, in other regions of the state, things function differently. So that ecology is not the same across the state. So we had guests from Buffalo. The way that they deploy programs there is different than the way we do it downstate. And I would say, not just because this is downstate,
Yes,
it's SUNY Downstate. So that to me is the opportunity, that middle piece.
Yes.
And raising what we did in terms of subpopulations.
This one.
Dr. Salifu, your vision for the Disparity Center, like we can change the ecology of how New Yorkers in our region experience care.
That's right.
That's the hope of what today is about, and yesterday from my point of view.
That, absolutely, absolutely. But anyway, I have a personal perspective. This is just a presentation. But I want to take you back. We have some time, that's why. So we can have this discussion. Can we get the lights back on? Lucky?
We actually, our speakers.
Oh, our speaker is here. Oh, very nice, very nice. Okay, so we can go into that later. Any other question? All right, so thank you very much.
Great discussion.